So thanks everyone for joining us to talk about long COVID tonight. Dr. Tucker's in the UK, so he's obviously got a lot of experience in this field. So as they've just about coming out of their second lockdown. Could you just forward the slides on, Neil, because I can't do that on your screen. So to begin with, I'd like to begin by acknowledging the traditional custodians of the land on which we are meeting today and pay our respects to the elders past, present and emerging. I'm sitting in Sydney on the land of the Gadigal people of the Aurora Nation. Just take 5 seconds and think about the lands that you're on today. Okay. I'm Jo Bruce. I'm one of the medical educators at Medcast. And I'm here. I'm just going to be doing the chat and funneling questions off to Dr. Neil Tucker, who I will now introduce, and he will tell you a little bit about himself.
Hi everyone, good evening. Thanks for joining us wherever you are in Australia and maybe other parts of the world. Very brief introductions if you haven't met me before. So I'm Neil Tucker. I'm a GP. I've been working as a GP in Oxford in the UK now for 10 years. I've been working with MB Medical for the last 10 years as well, doing basically just having a look at the latest research and guidelines that come out, collating it and then sharing with people around the country and indeed around the world, which has brought us to Australia and Medcast. So it's great to join you once again. I've never worked as a GP in Australia. I did work in Adelaide as a junior doctor for a year, which is one of the best times of my life, mostly spent not learning to surf despite trying, partly hampered by spending most weekends drinking some of the best wine in the world, which was on the doorsteps, which I deeply, deeply miss. But that's enough about me. Quick bit of housekeeping. So if you guys at home can just have your microphones switched off so we don't get too much interference, use the chat for any comments and questions. And when you're using that chat, just change that drop-down box, as Jo said. Some of you would have heard that at the very beginning, to all panelists, from all panelists to all panelists and attendees. And then you can actually have a chat with everyone in the group, which is what we're actively encouraging. And if you are getting any problems with your computers, your connectivity and the like, try turning off your cameras because it saves a bit of bandwidth. But equally, we're joined by Greg today from the Medcast virtual office. Ping him a message and he'll try and get you sorted out. So you probably joined us on a Hot Topics course before, or indeed on one of these evening clinics before. You know the score. Just kick back, relax, enjoy. We're here for an hour to have a bit of a chat about a topical subject. We'll do, as we usually do, we'll do based around clinical cases. We'll have a little break every now and again where Jo will be able to come through with any of your questions, any of your comments, and see how you guys are feeling about things out there. And we particularly want to make this one really, really interactive. So we're going to have a few polls, but I'm going to be asking a few questions that you guys can share around on the Q&A box as well. And then Jo can sort of pull it all together at the end. If you do have any questions, then do send them through to us whilst we're on the session, but also you can email us after this. So I'm on neil@mbmedical.com, or you've got Jo on jo.bruce@medcast.com.au. And just get in touch with us over the next few weeks or the next few months until we do the next course. Just I'll highlight some of the some of our little summaries that we do as part of MB Medical as we go along. Yeah, hopefully you guys will find this interesting. So I think probably this time last year, none of us would have expected for us to be in the position that we are right now. So I'd be really interested to know, what were your plans for 2020? What has not happened that you wanted to happen? Or have you managed to do your plans? I mean, that'd be interesting as well. I'll tell you what mine were. So my wife had decided that we were going to take a prolonged period off of work in the summer, which for us counts as about 4 weeks. So that was quite luxurious, and go interrailing round Europe with the children. So I've got a 6-year-old and a 3-year-old. I'm not sure as whether I've had a lucky escape or I've missed the holiday of my dreams. So I'm not sure right now, but I definitely didn't do that. I went to a rather tired seaside town called Weymouth instead, which if any of you have been to the UK and have had the misfortune of going to Weymouth, then you'll know that's not much of a comparison to what I was going to be doing. But yeah, let me know, let us know how and what you were going to be doing. Okay, so keep a lookout for this box. When we see this, we'll have a little sort of break, and Joe will just be able to reflect back some of your comments and answer some of your questions. And we'll have a few breaks as we go through the session. So, okay, this is the state of play at the moment. So I'm not going to give you loads of background about SARS-CoV-2 because you all know it by now. We've all been just sort of soaking it up for the last 9 or 10 months. So we're all pretty up to speed with what's going on. This is the state of play as of sort of this week, basically. Australia, you've had 27,000 cases. So most of them were in that big wave in Victoria. And you had that second wave in July and August, which you've done remarkably well at suppressing. I mean, Australia's done a really, really good job of keeping levels low. So I see there's around sort of this just a low bubble of about 10 cases per day in Australia, which is really pretty remarkable. UK, well, things have been quite different, as you probably all know. 1.5 million cases so far. We've had that second wave that's just peaking. As of today, we're just out of our second lockdown period, but we've still got lots of restrictions. And in my area, we're still quite limited in what we can do. So we can't meet up with friends, for instance, and go to a restaurant or a pub. If we're meeting up with people, it can only be 6 people. We've got to do it outside. Right now it's 3 degrees where I am. It's not particularly appealing. So, you know, things are quite different. And actually at some point we've had 27,000 cases per day. So that means that we've had lots of exposure to patients who've had COVID-19, and indeed quite a few who have then gone on to have long COVID. So let's just do a quick poll. I'd be really interested to know, have you seen a patient, managed a patient, looked after a patient who's had COVID-19 where you are? Because although your numbers haven't been high, especially if you're in the east, sort of southeast of the country, there's a reasonable chance that you might have seen someone with COVID-19. Have you had it yourself? You guys are ultimately you are the front line as medics. So about a third of you have had a patient with COVID-19. I mean, let's hope it doesn't go any higher than that. I mean, you know, you guys are doing a good job of suppressing things. There's obviously limitations going in and out of the country. Hopefully with a vaccination imminently becoming available, then maybe things won't change that much, but it's going to be a good few months before any of us manage to sort of vaccinate a significant proportion of the population. So let's have a look at long COVID, because this is the big topic now. I mean, we are very familiar in the UK at managing acute COVID, but the knock-on effect of that is that we're starting to see plenty of people who have got long COVID as well. So this raises a bunch of questions for us. How do we define long COVID? What actually is it? How common is it? And how likely are we to see it? Who's likely to get it? What symptoms are common? When should we be investigating people? And how are we going to do that? And is there any treatment that actually makes a difference for long COVID? So in the early stages of this pandemic, it became clear that some people did develop prolonged symptoms. In the early stages, it was all about the acute presentation, about making sure that people were safe, making sure that we could see who was going to get sick and how we could manage those people. And that was the big focus for the first few months. And then we started realizing that some people just didn't seem to be getting didn't seem to be getting completely better after the 2 or 3 weeks that they were being told they should be. And some people had very prolonged symptoms, and for some people, they were very troubling symptoms as well. So we've got some emerging data on that. We've also got assumptions that have been made about what we might expect with prolonged COVID symptoms as well, based on our experience of related infections such as SARS and MERS, which we know are closely related. We haven't got any consensus internationally about what constitutes long COVID. Indeed, that phrase is arguably not necessarily the right medical phrase for us to be using either, but sort of colloquially, it's the one that seems to have stuck. But we do have some guidance. So locally to you guys in Australia, you've got the RACGP. They've produced a piece of guidance a couple of weeks ago on caring for older, for adult patients who've got COVID-19 prolonged symptoms, and we're having in the UK, NICE and SIGN and RC, not PG, but GP collaborating on putting together a guideline, which is meant to be published this month. I see they've just published some draft guidance on it. So they're having a fairly rapid turnaround at the moment, as is the nature of what we need in a pandemic, but we haven't seen anything yet. So there are a few other resources that have published in major journals, and some information that's published from the RCGP, so there's an interim piece of guidance as well. We're going to have a look at some of that, and then some of the research that's come out in major journals pertaining to long COVID as well. So how do we define it? Well, currently this seems to be what we're going to call it in the UK. So after the acute period, which is up to 4 weeks, going up to 12 weeks, we're going to call it the ongoing symptomatic COVID-19. That's not very catchy, but I suppose it is descriptive, if nothing else. And then from 12 weeks on, they're going to call it post-COVID-19 syndrome. Most of us would probably prefer to just call it long COVID. I suspect most of our patients would as well. One of the sort of key sort of comments and recommendations that comes out of the guidance that we've got so far is just the acknowledgement that this is a genuine problem. It's a genuine syndrome. It's a real condition, and we are seeing lots of people who already have it. So I'm going to introduce you to Steph. So Steph is not a fictional sort of patient in this talk. We're going to meet quite a few of those. Steph is a real person. She's another presenter on the Hot Topics course, and a friend of mine. And she is she's a GP. She does loads of other stuff as well. She's hugely energetic, involved in loads of different things, like she does perinatal mental health on a national scale. She's got a specialist interest in obesity and goes to obesity conferences and gives talks. She's all over Twitter constantly. I have no idea how she does that. She's a mother of 2 as well. She's got a lot going on. And she works in a sort of basically in an emergency department in Kent, in the south east of England, which is one of the places that was hardest hit initially, and she works as a GP in the emergency department. So she was in the thick of things very early on, and so she developed classic COVID symptoms in March. And I'm going to play a few short videos of her experience of things as we go through this session, because it became quite clear to her that after a few weeks things were not settling down as expected. At what point did you then start to feel like this might be something that is going to keep going? It's not just going to settle down like we've heard the majority of people seem to with acute COVID.
I work 2 days a week clinically, and then, as you said, I do my NB stuff, my perinatal stuff, and I went to work. So I had the 4 weeks, went to work, and I'd get halfway through the day and think, I think I need a nap. And I was getting absolutely exhausted, and I was having to spend the next day in bed. So I'd work a day, sleep a day, work a day, sleep a day, work a day, sleep all weekend. And I was willing to say, right, we don't really know. You can feel rubbish after flu. So I thought 6 weeks, 7 weeks, that's fine. Once it got to 12 weeks and I was still doing that, I thought, and still having fevers, about 3 out of every 7 days, I reckon I had a fever. And I knew when the fever was coming. I could kind of spot my fever just by how I felt. And yeah, it just kept on going. So it was joint pains, fatigue, tachycardia, fevers. The dizziness had gone by that point, but by about 12 weeks, I was beginning to slightly lose my mind, thinking this is never going to go away.
So that's Steph. We'll see more about her experiences as we go on. So what's the chances of getting post-COVID-19 syndrome? Well, this was the first sort of major piece of research that published in one of the major journals. This was from Italy. Obviously, Italy was really, really heavily hit in the early stages. They were about a month ahead of us in the UK. And this was patients who'd been admitted to hospital, recovered, they were discharged and followed up in their clinic at 2 months. 140 patients. Most of them hadn't needed the most significant treatment. Most of them didn't need ventilation on ICU, but obviously they were ill enough to be hospitalized. Only 13% of them, by that 2-month period, were free of any COVID symptoms. 55% of them had 3 or more symptoms, and the most common ones that people got were fatigue, dyspnea, and joint pain and chest pain. So we can see a lot of people seem to get some fairly prolonged symptoms by 2 months. But that is a fairly skewed population because that's the hospital-based population. What about a more community-based one? Well, this is data from the COVID symptom study. And if you're not familiar with this, this is something that's been run in the UK. It's an app that people have downloaded and they input their symptoms on a daily basis. And it's not just for people who have been confirmed to have COVID. This is for people, for anyone to just get an idea about what's going on in the general population at the moment. And then, of course, they can correlate those symptoms to people that then test positive at some point for coronavirus. And they're collecting data from the UK. They're doing some. There's some people in Europe using this, and the US as well. It's a really big data set now. I think there's hundreds of thousands of people that are regularly inputting data on this app. And when this published in October, they were looking at 4,000 patients who had a positive COVID study, and they found that the rates of persisting symptoms were not as high as from that Italian study with that hospital-based cohort, but not insignificant. So at 4 weeks, at 8 weeks, 4.5% of people were having ongoing symptoms, and at 12 weeks, then 2.3% were still having symptoms. So there is this gradual trend down. So people do improve, but for a minority, 1 in 20 or so, it's taking 3 months or long. So 27 cases so far in Australia. We'd expect over 600 people from that second wave to have some degree of long COVID, which means they may still be getting symptoms even now. And 600 cases spread out through the whole of Australia is not huge, but it's not insignificant either. And that means that many of you will ultimately come across people who are struggling with their COVID recovery. So let's meet Dave. Dave's 54 years old. He lives in Inverleigh in Victoria. So he was in an area where obviously there was the big peak, but he's a little bit removed from the sort of major cities. He's a bit out of Melbourne. I wonder if any of you live in Inverleigh. Dave's not a real person, by the way, but do let me know. So he's a builder. He travels daily for about an hour or so to actually go to work to where he does the building. So he's mobile quite a lot. And in August, he developed some classic features of COVID. So fever, cough, fatigue for about a week. In the second week, he became more short of breath as his characteristic, more marked fatigue. In the third week, he's starting to improve a bit. He'd been pretty much bedbound up to that point, which is obviously unusual for him, but he's starting to get around the house again. He was pretty unwell, but he never saw the doctor. He doesn't really go to the doctors very much. He never went and got tested. He just kind of thought, well, you know what? I'm not feeling great. I live by myself. I'm just going to isolate and wait for things to recover. But things didn't fully recover. So in November, he's improved, but he's still having symptoms. And we're now talking 3 months that he's still getting symptoms. So let's do a poll. So can you diagnose Dave with post-COVID-19 syndrome? So what do you think? Would you diagnose him with post-COVID-19 syndrome at this point? Yeah, okay, so that's interesting. Yeah, so about a sort of 50-50 split, which is interesting. So, okay, let's have a think about post-COVID-19 syndrome then. So the working definition that we've got here in the UK is signs and symptoms that develop during or following an infection consistent with COVID-19 that continue for more than 12 weeks and are not explained by an alternative diagnosis. So do you need to have a positive test? That could be a swab, could be PCR, or it could be an antibody test after the event. Well, no, you don't, because we all know about the limitations of tests, particularly with a swab. We know that the false negative rate is maybe around 25% or so, and that's hugely variable depending on the person who's doing the test. And we know that there's limitations of who we've been able to test as well, particularly here in the UK in the first wave. Unless you were hospitalised, no one had a test, and there would have been tens of thousands of people who, well, probably hundreds of thousands of people who have had COVID who never got the opportunity to test. So, so having a positive test is not a prerequisite for diagnosing COVID or indeed for diagnosing post-COVID-19 syndrome. They've deliberately kept the definition open and broad, because there's not one type of long COVID either. It's going to be a number of different syndromes for people, because there's different aspects that will be affecting individuals. So you might get direct damage to the organs due to the virus. You might get sort of secondary damage due to the inflammation and immune response that we have. Theoretically, we might have a persisting viremia due to weak or absent antibody responses, although that's still quite heavily debated. And even if you do have a persistent viremia, a bit like, say, you might consider with something like glandular fever, or even, I suppose, chicken pox leading into shingles. I don't think you would necessarily assume that, we shouldn't assume that people are infectious for all of that 12 weeks. I think the general consensus is that they are not. I mean, yeah, it could be reactivation of the virus, like with chicken pox, but it could be also deconditioning. If people have been immobilized for a period of time, or indeed if they've been hospitalized, and particularly if they've been ventilated on ICU, then deconditioning can cause significant issues for people, really quite prolonged rehabilitation from that. And of course, there can be mental factors that play into this as well. So who gets post-COVID syndrome? Well, it's becoming quite clear that there genuinely is an enduring effect on multiple systems throughout the bodies. And this was a really interesting paper that published maybe a week or so ago. So a lot of this research is really, really recent. We've got more stuff coming out all the time that informs us about long COVID. So this is another UK study based in 2 hospitals around the UK. It's an ongoing study, and they particularly wanted to look at young, low-risk people with long COVID for more than 3 months. And they went on, they did MRI scans on them, they did blood tests, and they did questionnaires about what symptoms they were experiencing. So in this early sort of stages, this is currently in a preprint, but in these early stages, they've got 200 patients, average age 44. Most of them had not been admitted to hospital, so they've had sort of mild or at most moderate acute COVID. And they found at this point, 3 months later, 2/3 of them still demonstrated some impairment of at least one organ. 25% of them had multi-organ involvement. So most commonly, that's the lung, heart as well. We know that there's big involvements there, lots of early complications in terms of lung and cardiac issues associated with COVID, but also kidneys, liver, pancreas, spleen, a huge range around the body of organs which are affected. And so they concluded that these longer term effects are very common, even in this low risk population, even people with mild symptoms. And maybe this goes some way to explain why people experience post-COVID syndrome, because we don't really understand why people still get some of the symptoms they get. So anyone can get it. There are some risk factors that have come out of the COVID symptom study for who may be at increased risk. So particularly if you have lots of symptoms in that first week of illness. So if you're, it's not necessarily so much about how unwell you are, although that probably factors into things, but just the number of symptoms you get, increasing age, female gender. There's a weak association with increased weight, and then there's an association with asthma as well. They didn't find that other comorbidities seem to influence this, and why asthma should do that, no one's really sure. It's one of those things, it wouldn't surprise me if they got some further data and they found that maybe there wasn't a definite association there, but for now, these are those are the risk factors. So, and maybe sticking to the chat box, I'll be interested to know, so a few of you have had patients who have had acute COVID. So how many of your patients, or do you have any patients who have long COVID in your practice? What were the clinical features there, and how long have they had it now? Is it still ongoing? Is it weeks or months for them? So what are the symptoms that people get? Well, many and varied. They may be linked to the underlying cause of their post-COVID syndrome, or they may be completely independent. But there are some common themes that come out of this. So, I mean, this is the most sort of a common group, but as you can see, I mean, yeah, profound fatigue, breathlessness, cough, muscle aches and body aches, high on the list. But there's a huge amount of stuff: palpitations, ongoing fevers, headaches, anosmia, neurocognitive issues, thromboembolic issues, gastro disturbance, metabolic disturbance. I mean, the list goes on and on. Essentially, you can pick a symptom, and it's probably able to be linked with COVID-19. There are some themes that come out of this, though. So there are common elements, and the three most common for post-COVID syndrome are profound fatigue, this relapsing and remitting pattern where, as Steph described, it goes away for a few days, then it comes back for a few days, and that pattern repeats itself, and then brain fog. So there is significant neurocognitive sort of sequelae as a result of COVID-19. We know that coronaviruses cross the blood-brain barrier. It's speculated that's why we see some of these effects. And we shouldn't underestimate the impact that these symptoms can have on a person. It may render them unable to manage day-to-day tasks. They might not be able to work, and it definitely has an effect on their mental health. So I think we've probably got a Q&A session coming up in a sec, but let's just see how Steph found these symptoms.
Yeah, and do you know what? That's the psychological torture of it, I think, is that you think you're getting better. And anyone who kind of hangs around me long enough knows I do quite a lot on Twitter, and so I'd put, oh, I'm feeling better, and then 2 days later I'd go, well, that didn't last long, did it? And that's really hard, because you think you're getting better and you think, I've got my life back, and then sometimes it would last a week and I'd think, COVID has left the building, we're doing well, and then it would come back. And I found that psychologically really tricky. Okay,
so over to you, Jo. What's been going on the chat?
So there are quite a few people have actually either had it or have had patients with it, and they're reiterating really what you've said about the fact that there's lots of lethargy, can't physically drive a car, needs to sleep all the time, multiple symptoms. There's some ongoing cognitive impairments like post-concussion syndrome in one particular, which fits in with the symptom list of symptoms that your colleague was just talking about. Someone suggested, and was just in the middle of trying to chat to them about the low vitamin D, and they actually work in Birmingham in the UK, I presume, and they find the majority of patients have low vitamin D, particularly in those who cover up for cultural reasons. I'm just trying to work out whether that's a comment about whether these are all linked to vitamin D deficiency or whether that's something. So anyway, we'll come back to that one. Yeah, but mostly, yes, as you've said, it's the cognitive impairment, I think, that really gets, that is really, really challenging for most people. I've got a patient who's got a lot of respiratory symptoms, and she's had COVID 4 months ago. Marked difference to the anxiety symptoms for anxiety that she normally has, but it's difficult with the lack of numbers to convince her that this might be long COVID as opposed to her anxiety coming back. And of course, the more she's getting symptoms, the more anxious she's getting. So it's becoming this kind of treadmill for the poor patient. But anyway, so that's all about the patient. Yes, so the vitamin D, he was wondering whether the low vitamin D is significant. I have to say probably over here where we don't have large amounts of loss of vitamin D because it's sunny all year round, it's not really something that we have found that's linked. Someone's had constant tingling in their hands and feet. Is that something that you've seen, Neil? Before we get into too much of a consultation here, Will.
Yeah. Well, no, I haven't seen that in any of my patients that have got long COVID at the moment, which predominantly have been struggling with just fatigue and or breathlessness. But it's not impossible that you can get some kind of peripheral neuropathy with this. We know that there are that is a potential problem. It's a potential complication. On the other hand, as we'll talk a little bit later on, there's lots of reasons why people get these symptoms that we need to think about beyond COVID as well, and that's particularly true in somewhere like Australia, where your rates of COVID have not been that high. So, how are we going to manage post-COVID syndrome? Well, there's not a lot of research out here to base our management strategies on, but there are some good sort of sensible expert-driven documents that have come out, and this one in the BMJ was probably the seminal piece of guidance that's come out so far. We're also going to have a look at what the RACGP have produced, which is they actually use the BMJ as a reference source in there, and a few other papers that we've been talking about and we'll talk about in the rest of this evening. And that's a useful document for some broad brushstrokes of how to manage this. And over here, we've also had some initial, again, pretty broad brushstrokes guidance from the RCGP here as well. One video just to highlight, if you want to get a really good idea about how long COVID affects people, there was this BMJ webinar a few months ago, which is now on YouTube. So if you just look in YouTube BMJ long COVID, this video will come up, and it's a talk with a number of medics who have all had long COVID, and it's really, really eye-opening if you haven't seen people who have had this problem before. So what's our role? Well, the first thing to say is just sort of having a relationship with the patient, understanding them. Being a GP is probably one of the most important things we can do to help people with post-COVID syndrome. So the RCGP said we should believe our patient, listen to them, show empathy, and acknowledge the diagnosis. The BMJ very astutely says we should honour the story of the patient whose protracted recovery was unexpected, alarming, and does not make any sense. Going back a year ago, none of 2020 would have made a lot of sense for most of us, to be honest. So I think that's very reasonable. This is from the National Institute of Health Research in the UK. They found in a qualitative piece of work that they did of people who had long COVID, they found that the feeling of not being believed was particularly difficult. And so they really don't want their sort of trusted healthcare professional to not believe them. And indeed, that the BJGP found in a recent piece of another piece of qualitative research that 3/4 of people felt that listening and empathy from us was beneficial to how they were feeling. We know that there's an important role for sort of the doctor as a drug. It always has been, and it's part of what we do in general practice. So most people will improve over that 4 to 8 weeks period. So for those, we can just support their recovery. We don't really need to do anything apart from just acknowledge that they've not been feeling great and reassure them that things will improve. But for people who have got ongoing symptoms, we need to critically review those longer symptoms, particularly new symptoms that come about, or if they start getting worse rather than following the expected trajectory to improvement. We need to consider if this could be COVID, but we also need to bear in mind about alternative causes, and then we need to investigate or refer, if we need to, where people do have persistent, troubling or uncertain symptoms and signs. So that brings us on, when should we investigate? well, just keep in mind the goals of investigation. It's to identify unwell patients and hopefully identify the complications of COVID-19, excluding other causes of ongoing symptoms, knowing that actually for a lot of people, particularly in Australia, that most of the time it's not going to be COVID. And then the goal of the investigation is to provide some reassurance to the patient who otherwise maybe there's not much that we can do. So what are the complications? Well, this is a screenshot from the RACGP guidance, specific sequelae of COVID-19. I mean, you can basically look down that list and see that there's one of everything on that list. The reason it's many and varied. So remember, COVID causes endothelial inflammation and damage. I mean, that's endothelium anywhere in the body. So particularly that's true in the lungs and the heart, but in all other systems as well. Plus you get this hypercoagulable state with immunothrombosis. So that's where you start getting clots form out of a combination of platelets and white blood cells, where they're kind of interacting with injured endothelium. And then, of course, coronaviruses do cross the blood-brain barrier, which might explain why we're seeing some of these central nervous system effects as well. So Dave, so he's now 15 weeks since his first illness. He's still got a cough, shortness of breath, intermittent severe fatigue and brain fog. He's still off of work. He's worried about his finances, quite understandably. He just desperately wants some help. So what are we going to do? Would you investigate Dave's symptoms at this stage? What would you do in practice? So I think we can probably all agree that he's got COVID or had COVID, and he's now got post-COVID syndrome. Doesn't matter that he didn't have a positive test. He's got classic symptoms. If you get classic symptoms of a disease during a pandemic of that disease, then it's reasonable to assume that they have that disease, I think is the bottom line, especially in somewhere like Victoria. So he's got post-COVID-19 syndrome. 15 weeks, gradually improving, but he's not getting there yet. Basically, almost all of you would say, yeah, let's investigate at this point. Fair enough. So let's, before we talk specifically about how we investigate, let's just think about some of the common features that people are going to get. And predominantly, that's going to be breathlessness. That's one of the most common ongoing symptoms associated with post-COVID-19 syndrome. So there's a whole range of reasons why people might get this. So it could be that it's just resolving infection, it could be deconditioning if they've been particularly unwell, and that might lead to disordered breathing. But also there's other things we should consider. So we know that there's we think probably a high rate of lung fibrosis that can develop after COVID-19. We saw it a lot in SARS, in MERS, so around a third of those patients had fibrosis. There was some improvement in fibrosis after those infections within a year or two, but indeed some patients continue to have sort of permanent damage. A lot of that is driven not so much by the infection, but the combination of inflammation and then ventilation techniques. And I think it's fair to say that around the world, kind of intensivists have started to understand this a bit better and manage these patients a bit better. So actually, it seems we're looking at lower rates of fibrosis in those severely unwell patients than we probably saw in SARS and MERS, but we still need to be mindful about this. It could be a PE, and that's quite common, particularly in the early stages, particularly if people have been hospitalized, very high rates of VTE there. It could be pulmonary hypertension, which is kind of also linked to that hypercoagulable state of the smaller vessels around the lungs, leading to pulmonary hypertension and therefore sort of effects on the heart, which might then also be linked, although there's also separate mechanisms why people might develop heart failure, myocarditis, rhythm disturbances as well. So there's a whole range of things that we need to think about when we're investigating or when we're examining someone and assessing someone with breathlessness. So top tips then for people with breathlessness. So if they've got more cough than breathlessness, then often that's best treated with breathing techniques. And in the BMJ paper, there's a very good little box on how to help advise people with breathing techniques. There's some specific things that they can do, which we won't go into now because we haven't got time, but can make quite a big difference for people. Also, sort of anecdotally, I've had quite a lot of success for some of my patients who have just gone to see a physio to help give them some dedicated advice about sort of like getting their breathing sort of back onto a normal pattern, and that's worked really well for some people with breathlessness. Having a pulse oximetry at home may be of use. I mean, it's quite useful to check whether they're having desaturations on pulse oximetry, particularly with exertion, which we tend to think more about in acute COVID, but it can be worth doing that as well in long COVID, and maybe getting patients to keep a diary, because if their pulse oximetry is fine, then actually it can be quite reassuring if they can see over a longer period of time that they're not actually going to be unwell or in danger due to what they might perceive as something that's driving low oxygen levels in the body. Be mindful that severe breathlessness is rare if people haven't been hospitalised, and we should start thinking about other pathologies, particularly think about things like PE. If patients have had COVID pneumonia, which most people who have been in hospital with COVID probably have, then they should have some ongoing follow-up, and they need a chest x-ray at 3 months to see if there's any ongoing abnormalities, and if they are, then they're going to need to have further input. So the recommendations over here would be that they go to a post-COVID clinic, which is generally run by a respiratory team, and they will get ongoing follow-up, and the chances are actually they'll get a wide spectrum of tests. So they'll get a high-res CT chest looking for fibrosis. They'll get a CTPA to look for any clots, and they'll get an echo to assess the heart. They might get sputum sampling, things like that as well. And then pulmonary and cardiac rehab can be useful for people. If they're just having a slow recovery, but they're otherwise okay, then both of these rehabilitation methods can be quite helpful for those groups. Now, fatigue is the other big issue, and there's lots of parallels here with managing ME and chronic fatigue syndrome, which is really interesting that for years and years and years, there's been a lot of uncertainty in the medical community whether ME and chronic fatigue syndrome is anything other than a mental health complaint. A lot of skepticism that there's really some physical thing underpinning that. And I think COVID-19 has really made us reassess the way we evaluate people with chronic fatigue syndrome, because we're seeing a lot of people who have very, very sort of similar features, who clearly have had COVID-19 and are starting to struggle. So it's just interesting the way it just changes the way maybe the medical community might be thinking about this. And actually part of that, we've seen a draft NICE guidance published in the UK, which significantly changes its recommendations about how we manage ME and CSF. No quick fix to the fatigue, unfortunately. There's no treatment that's going to be particularly, or should we say drug treatment that's going to be helpful here. And the traditional advice that we used to give to people with ME of graded exercise and CBT is no longer recommended. And so this is a really useful piece of guidance from the Royal College of Occupational Therapists. This is the 3 Ps. So pacing. So rather than graded exercise, we understand that pacing these days is likely to be the most effective tool. Patient-led, they can see how they're feeling, whether they can sort of set their goals and set their targets. They can then plan their day so that they can avoid overexerting themselves, prioritizing the things that they need. And it'd be well worth signposting people to that occupational therapist resource if they're really struggling. It's a really good piece of advice. And this is how Steph found issues with fatigue.
And it's brain as well as body. And so I worked out, for example, that Zoom meetings, or Teams meetings, which we know are different to meeting people face to face. We know that the way that our brains function on them is different. They would exhaust me. I'd have a meeting and I'd have to go to bed. I mean, that's insane. Like, I'm just chatting to people. A day at work meant a day in bed the next day. And I stopped feeling bad about that. And I'd say, right, okay, I've had a day at work. Now I need to have a day of resting. Physical exercise, to be honest, I was too scared to do. And I'll still be honest, I'm too scared to do it now. I have a very expensive Peloton bike that hasn't been used for a very long time. But it was the head stuff. You know, I'm trying to present. Zoe laughed at me when Zoe and I were presenting the last women's health course. I'd be all, you know, lively, and I had a standing desk because I find that's easier to present. And then I'd literally lie on the floor the minute I handed over to Zoe, and I couldn't get up for a while. And I had to learn that those things were okay for me to do.
So there is some official guidance on returning to exercise if people have got post-COVID-19. So if they've had a relatively mild illness and they've recovered, then basically they suggest just a week of low-level stretching and strengthening exercises before they can go back into something more cardiovascular. They've still got very mild symptoms. They basically say that they should be not doing anything more strenuous than slow walking. If they've got longer-term persisting symptoms, but they feel that they can exercise, they said limit the activity to 60% of your maximum heart rate until 2 to 3 weeks after your symptoms resolve. I guess some of our patients might find that quite tricky to work out, but I guess it's kind of, well, how do you feel when you're at 60% of your maximum heart rate? You're a bit puffed out, but not too bad. If people have been very unwell, let's say they've been on oxygen, then the recommendations are for a respiratory assessment before they resume exercise, which I think is rather, in the UK, that's a rather sporting recommendation because that could account for quite a lot of people. I'm not sure how the specialists would cope with that. And if they've had cardiac involvement, then they need cardiac assessment for resuming. And all of that's particularly true for people who are sort of doing more, doing sort of higher level sports and who are doing a lot more sort of stressful activity. Let's just, what last video with Steph, and this is more about the sort of the cognitive side of things.
So I've said to a few people, because I've had depression for many years, and that's been quite good practice for this, because I kind of got, when you have depression or anxiety, your brain just doesn't work properly. So it's all a bit like, well, brain fog, or postnatally when you're like, I literally can't do anything. And it felt like that. And I, I'm someone who can whip up a PowerPoint presentation without much, hassle. And it would take me hours and hours to do stuff that before would have taken minutes. And I think making peace with that and saying that's all right, and not doing stuff that is really hard is okay. And you will have noticed that I'm not doing any of the MB webinars apart from Women's Health at the moment. And it's because I couldn't get it together to do it and do it justice. And although I hate that because I like presenting, it's much more sensible for me to say, actually, I just can't do this. And so I didn't, because I couldn't process the information properly.
So I think that's quite a common theme with lots of people with post-COVID, that their brains are not quite functioning as they normally would do. And I think what one of you guys at home said earlier about it being very akin to post-concussion syndrome. I mean, I think that's a good analogy. So this is data not from COVID, but from other severe illnesses. We know if people have been in critical care that at 2 years post-critical care, 40% have anxiety, 30% have depression, 20% have PTSD. So ongoing mental health issues are very, very common. And then there's the neurocognitive damage as well, due to the hypoxia, inflammation, and the rest. And so lots of people get this brain fog, particularly in the elderly. We're seeing some enduring cognitive impairment as well, and around 1 in 5, particularly in the older groups who have been in hospital, still show some impairment that wasn't apparent before at a year. And so this is, again, not for COVID. This is some data that's come out of people who have been critically unwell, and particularly with SARS and MERS, but it's likely to be the same with COVID too. And at that point, effectively, they get an established diagnosis of established cognitive deficit or dementia. There's societal effects as well, and not being able to go out, lockdowns over here, not being able to travel in Australia, maybe not being able to visit family in other countries. All of that has a knock-on effect. The BMJ does counsel us to avoid pathologizing the majority, because actually most people will be okay and most people will be able to just kind of get on with things. But if they are really struggling, then there is a role for mental health services, and if they've got cognitive impairment, of course, memory clinics. I'm conscious of time, but let's see if we've got any kind of questions or comments with you, Jo.
There's not really huge amounts. I think everyone's just listening and taking it all in, to be honest. I mean, we're certainly, rather than seeing the neuro effects from and mental health effects from the disease itself, we're certainly seeing it for long periods of not being able to see people and the societal effects over here. I can't find a psychologist in the eastern suburbs in Sydney for love nor money for about 4 months. Their wait times are at the moment. Because they're so filled up. There is a question just come through though, Neil, which you might be going to answer in the next bit, but so I'll leave it to hang. How optimistic should we be about the recovery from this?
Yeah, well, I think we can be optimistic, and we should be positive with patients, because although we don't have the really long-term data for obvious reasons yet, there's a good reason to think that the vast majority of people will have a full recovery without sort of any sort of particularly troubling long-term symptoms. And that COVID symptom study that just showed the gradual improvement over time. I mean, realistically, that at 12 weeks, there's less people with symptoms than at 8 weeks. At 24 weeks, there will be less again. But there may be some that do have permanent effects, so particularly cardiac and maybe lung fibrosis as well. So I mean, that brings us neatly on to when we should be doing some tests, and we don't want to blanket test people who have got long COVID. The BMJ suggests being selective and doing it for specific clinical indications, as we always would do, and that lots of people may not need any tests whatsoever. If they're just having that gradual improvement, then we can be quite hands-off. But if people are not improving as we would expect, particularly by that 3-month mark, I think there is merit in doing some basic blood. So things like doing a full blood count, making sure they're not anemic, check their renal function, make sure they don't have renal failure as a reason of why they might be unwell and tired at the moment. And that's a common theme with most of these tests. So ferritin is being used there as another sort of inflammatory marker, creatine kinase, obviously, because they may be getting ongoing muscle aches. Chest x-rays, because we know of the chest involvement, ECG because of the cardiac involvement, urine analysis, just to rule out any other kind of thing. So all of that's fairly basic stuff. But then they also sportingly suggest maybe we check a BNP or NT-proBNP, depending on what you're using where you are, to think about maybe assessing for heart failure a bit more. What about checking a troponin, maybe for myocarditis and or indeed even acute coronary syndrome, and maybe checking a D-dimer for thromboembolic disease. The problem with all of these is that, of course, we see false positives with these, and this is a really complex area. Particularly in acute disease, we're likely to see all of those be elevated. I mean, D-dimers in particular are markedly elevated by just COVID-19, irrespective of whether they have VTE. So a positive result doesn't necessarily mean that they've got that condition. How much does that help us? That's difficult to know, but a negative result certainly can reduce clinical uncertainty, and otherwise these patients are probably going to need to be further investigated via a specialist in any case. So the sort of the notion about it being a false positive is possibly less important than maybe trying to get that negative result that we can actually take things further forward and provide that reassurance for us and our patients. There are some standard recommendations here in the UK. If you're a hospitalised patient, you should have a follow-up X-ray at 3 months. So if you have patients who've been in that position and they don't seem to be getting that, that's worthwhile doing. If they've got ongoing respiratory symptoms, do a chest X-ray. Consider doing a SATS sort of desaturation test. If they're an adult, then you could cautiously do one of these exertional tests, like the 40-step test. And if they've got persisting abnormalities on a chest X-ray or their SATs, or ongoing troubling symptoms, then a bit like we've already suggested with the breathlessness, then those patients do merit some further input. Again, I just sort of stress we needed some clinical judgment here, because if they're gradually improving over time, that's what we would expect, and we can be a bit more relaxed about that. But if they're just not really getting any better, then we need to start thinking a bit more sort of out of the box. Those people who've got sort of ongoing fatigue and fevers and things like that, rather than maybe breathlessness, those simple investigations may be all that they need. And there are some specific recommendations from the RACGP as well, actually, specifically about older people. They're just reminding us, as with any condition really with older people, there may be atypical symptoms. So in that group, particularly if they've had, if we know they've had COVID, maybe think about proactive surveillance, early investigation of ongoing symptoms, and again, just reiterating the role for checking SATs and blood tests too. Lots of resources that are coming out. I mean, I couldn't find anything specific for Australia with long COVID, but you might well be able to get access to some of these from the UK. I mean, there's one that's specifically set up about by the NHS, which is a decent website with some sensible recommendations for people. There's also one from a London hospital, which is this post-COVID-19 information pack, which has been very useful as well, which is available on the Homerton Hospital website, and people can download the PDF of the information pack for free. And then let's just bear in mind that whilst our thoughts in 2020 have been all about COVID, I mean, particularly in Australia, you know, not just everything, but most things are not coronavirus. And this is data from the UK, but just in our first lockdown in March, we saw a 40% drop in acute coronary syndrome admissions in England. Even sort of further into the pandemic, we saw a 16% drop, and no one believes that we've had 40% less heart attacks in February or March. People just haven't been coming in. They've been having these problems and just ignoring it. And there's no doubt that that's led to an increase in out-of-hospital deaths, potentially for those survivors, longer-term complications, which are worse than they should be because they've missed that acute treatment, and are more likely to have recurrent events due to the lack of secondary prevention. So just bear in mind that we as GPs, we need to keep an open mind as we assess our patients. So lots of uncertainty here, a lack of good data at the moment, but there is sort of ideas that seem to be coming into consensus. We know that long COVID is going to have a big impact for some of our patients. One of the biggest things we can do is listen, acknowledge the impact of those symptoms, keep an open mind, keep the differential broad, consider symptom-led targeted investigations, and then signpost people to useful resources to aid their recovery. Any last comments, Jo?
Not really. I think, you know, it's an interesting thing, isn't it? When patients come and see us, they seem to want some kind of medicine or something to get better, and there really just isn't anything for this. It's all about doing it for yourself, with our guidance perhaps and support, but it's a mixture of time and doing it for themselves. I think that's fairly challenging sometimes too. And we're not even beginning to see what's been missed because of this. I did have one patient who had clinically had torsion of the testes and refused to go to hospital in March, April time because he didn't want to get COVID. That was an interesting discussion, and I won't tell you the outcome, but it was people were very, very scared, and I don't think we're going to see for a long time what's been missed.
Yeah, I think you're right. I think it's going to come out over months and years. We'll be picking up stuff that normally we would have already been completely on top of. So, all right. Well, thanks so much for taking the time to join us this evening. I'd be really interested to hear about your experiences of COVID and long COVID in a year's time. I wonder where we're all going to be, but I hope that I hope that the next few months are fine for you all. I hope you get a vaccine very quickly, and I hope everything gets back to normal over the next few months. So as per usual, if you can take the time just to complete the course evaluation, you'll see that you're taken to a survey when you finish the presentation here, and we need to get your evaluation for you to then get your certificate of attendance. So please do complete that. And then just we've got a few actual hot topics courses coming up. So the new series is going to start in February. We'll do that over a series of evenings. We've also got a women's health day and a diabetes hot topics day as well. So all of those are coming up in 2021. So do keep a lookout for them with Medcast and MB Medical. And if you sign up early, there's a discount too. Go for your lives, and I look forward to seeing you in 2021. So, oh yeah, the next one, I think this is a free one, isn't it, Joe? So the next clinic that's coming up is a cardiovascular clinic in late January with one of my colleagues, Sarah Davies, over here in the UK, and Richard Griffiths over in Australia. So please do join us for that. And otherwise, have a fantastic Christmas, have a good New Year, and we'll see you soon.
Thank you, Neil.
Great. All right. Take care, everyone.
Take care. Thanks, everyone.